Good afternoon and welcome to the Health Overview and Scrutiny panel. I'm Councillor Judith Smythe, Vice Chair of the panel, and because the Chair is unable to be here, I'm going to be chairing this meeting. Housekeeping things. If the continuous fire alarm sounds, please evacuate the room and public gallery by the stairwells. Don't use the lifts. Please assemble at Queen Victoria statue in Guildhall Square. And in order to comply with the Guildhall Trust Fire Marshal regulations, anyone who signed in at the Guildhall reception desk should sign out when leaving the building at the end of today's meeting. Can I draw everybody's attention to the fact this is live web streamed and this meeting will be streamed. Everybody speaking via a microphone will be on the camera. Members of the press and public are also permitted to record the meetings on the understanding that it neither disrupts the meeting nor records those stating explicitly that they do not want to be recorded. Is anybody wanting to make that statement and exempt themselves? That's just as well, because we're doing a public function that should be seen to be conducting it. Good. Please can everyone use the microphones and remember to switch them off when they've finished. I've got a terrible habit of not switching them off, so don't hesitate to remind me. I'm going to start with doing introductions around the table. I'm Judith Smythe. I'm a councillor for St Jude Ward. Can I go to you first? I'm
Gillian Harris, councillor in Havant Borough Council. Thank you.
Do please put your...
Councillor Leslie Minahan for Hampshire. Thank you.
Apologies for being slightly late, Chair. My name is Councillor Mark Jeffrey, St Thomas Ward, Portsmouth City Council.
Councillor Susie Horton, Central Southsea Ward, Portsmouth City Council.
Hello, I'm Wendy Rees and I'm the Managing Director for Hampton Isle of Wight Healthcare for Portsmouth and South East.
Good afternoon, I'm James Lowell. I'm the Chief Commissioning Officer for Hampshire Isle of Wight Integrated Care Board.
Afternoon, James Rhodes, Director of Primary Care, Local Care and POD, the ICB.
Afternoon, Simon Barson, Chief Operating Officer at Portsmouth Hospitals University Trust.
Councillor Jonathan Brown from Gospel Borough Council.
Lisa Gallagher from Democratic Services.
Thank you all very much. Members have read the reports, so please just highlight the developments or very significant things that you hope that we've picked up, or any developments that have occurred since publication. Got apologies from Councillor Oliver, which is why I'm in the chair, Councillor Cordy and Councillor Michael Bennett from the Winchester City Council. Are there any declarations of interest in things that are in the papers and the agenda? No? Thank you very much. So we're going to start with the minutes of the previous meeting, which unfortunately I wasn't at. So I've got a matter arising I'd like to ask, but let's just go through them page by page. Page 1, 2, for any corrections, 3, 4, 5, 6. So no, I can't sign them because I wasn't here. What's the procedure for that?
We just need two people that were needed to propose and second.
Okay. Have you? There are two. Councillor Jeffries and Councillor Horton will sign them.
Do you want to? Happy to second. Yeah, you second.
Okay, that's great. If you could arrange that with Lisa either after the meeting or during, that would be great. Is there any questions, matters arising that are not included in the agenda? So I have one, which is on page 5, about the decision to withdraw service at Oak Park in Havant without endorsement for the ICB. I wondered if you could explain how that could happen without the ICB endorsing it, and what the consequences are and what the progress has been over that. I'm not sure to whom I'm directing the question. Thank you,
So
James.
I was going to cover that in my update, but I can cover it now, Chair, if that's helpful. So working with the provider organisation that were contracted to provide services from that building, they said they would like to serve notice and we refused to accept the notice, i.e. saying we still need you to continue to provide those services from that site. Unfortunately, they then just exited the facility and continued to provide those services in a similar site nearby but not close enough, so we deemed that not acceptable notice, and we're now going through a formal process with that organisation at the moment to see what we can do to either get them back to provide the services they're no longer providing or work through the formal mechanisms we've got. I can't say much more than that at the moment because there's a formal process happening. However, colleagues at Portsmouth Hospital are working with us to see what other services they can provide on that site as an interim measure, and we're talking to them about what the future might look like if the provider that we've contracted to provide services do not go back into that facility, how we might re-provide the services for that local population. We absolutely recognise that it's a valued service for the local population and we're committed to providing that, and at no point did we say it was acceptable for that provider to cease providing those services from that site, and that's the formal process we're in at the moment.
Does that mean you stop paying the provider? Or I don't know how that works, having been a health commissioner before.
So that's confidential at the moment because we're going through a contractual mechanism. There's a raft of different contractual mechanisms we can use. There's NHS standard contracts that we're adhering to, but the specific mechanism I can't discuss at the moment in public because we're working with that organisation.
Was the contract written properly? Was that an issue?
So again, I won't go into any specific details, but where we are at the moment is just that formal process.
Yourself.
Dealing with this issue now because it comes up later in the report. I was going to ask my question. So, Alan Mack MP seemed to produce a report saying he'd managed to reinstate some of the services, and I wondered if you could explain what he was referring to, because as far as I can see, there aren't any reinstated services. Thank you.
Yes, so ultrasound, for example, has been re-provided by Portsmouth Hospital, so they're already back in there providing that service. And there's a number of services that are still being that are unaffected and they continue. So mammography, neurophysiological assessments are still being carried out there, ophthalmology assessments, and from April, fibro scans will also be provided from that site. And we're just working through the other services that have ceased at the moment and how we re-provide those.
Sorry, so just to clarify that because I know that not all of the services were withdrawn in the first place. So what you're saying is that ultrasound and fibro scans are now being reinstated or will be from April?
So at the moment we've still got ultrasound, neurophysiological assessments, ophthalmology assessments and mammography are still there. Fibro scans going back in from April. So x-rays at the moment aren't, but we're working on how we can get that back up and running.
We'll pick this up again during your report because it's quite a big issue. Thank you. Any other matters arising? And members will have noted the proposed date for 25-26 municipal year at the end. Thank you. So we're moving then on to agenda item 3. Agenda item 4, Hampshire and Isle of Wight ICB update. We have James Roach and James Lowell here, sitting in the middle over there. Over to you, please.
Thanks, Chair. I'll take access. So as always, I provide an update on primary care access. The only significant change from last time is that January data suggests a circa 10% increase for Portsmouth on the number of appointments last January. Overall across the patch, that's in line with what else we're seeing in terms of additional activity through general practice. For Portsmouth, we're tracking a 4.5% increase February, March versus the same time last year. The key point, I think, where it does differ, that's higher than the South East Hampshire average, which is positive, I think. But the other area it differs is the circa 52% of those appointments are with GPs, which reflects quite a high level of acuity and need still being managed in general practice. So the hospital is busy, community services are busy, general practice is busy. There's a lot of demand out there at a high acuity. On dentistry, you've got a bit more sort of detail that came through the briefing after the last meeting. This year now we've commissioned an additional 340,000 UDAs for the area, our UDA utilisation rate is 77% year to date, where it was 2 years ago is 56%. So there's been additional activity commissioned. In 26-27, we're going to commission an additional 81,000 UDAs for the city, which is positive. Units of dental activity, apologies, which is positive. That neatly aligns with the opening of the dental school in October. And you might have seen the news today that from 27, there'll be an additional 50 places per annum through the medical school as well. And we discussed this last time in terms of ensuring that the dental school rather get a fair apportionment of trainees. So very positive in terms of dentistry. We touched on pharmacy last time. The only other point I'll make, we don't talk about optometry often here, but some really innovative work with our optometrists around hypertension screening and also smoking cessation as well. So we are looking at how we expand the range of services into primary care. So access is up, variety is up, patient satisfaction remains higher than it has been previously, and we've got interesting and exciting plans around commissioning additional dental activity as well. The one final point around dentistry is the number of unique children being treated by an NHS dentist is significantly higher than last year and the year before. That was an update I received today, and I'll provide the committee with the data. So that's a positive, I think, in terms of oral health promotion and reducing health inequalities.
Thank you. Any questions or comments from people? Jill.
Sorry, I've got another question on the Oak Park situation. Is what communication?
I've just paused there because we've just done
Well,
primary care.
Yes, but it's in this report, isn't it?
I'm coming on to, yeah.
Oh, okay. It's not. Sorry, I thought we were doing this. It's all in the same report. But anyway.
Yes, it is. It is what the public talk to us about all the time. And we're just, yes, middle of item 4. Yeah. So sorry. Anything else about primary care access to dental, GPs, and the interesting comments made about ophthalmology, which I think should be very good.
Thank you, James. Nice to see you again. Why is the increase in demand? And you talked about acuity. Thank you. I'd just like to unpick that a little bit, if we may.
Yeah, so we are seeing more demand for patients to be seen on the day as an urgent case. So we've extended commissioning of same-day access. So we are opening up more demand, but I think it's fair to say that we have seen probably a greater incidence of respiratory conditions and long-term conditions having to be managed in the practice. So some of it is sort of seasonal. We can split that by clinical condition, but we are opening up more routes for demand as well in terms of same-day access.
So you're almost a victim of your own success, so to speak.
Yeah, it's just difficult, I think, as I'm sure Simon will reflect later. Demand is up across the whole system, and patients have a greater expectation now in terms of what they expect from general practice and how they access services. So some of it is more capacity, some of it is changing patient expectation as well. So we need to look at it in the round. So the key point to be aware of is next year there's a mandated national target that all practices need to see 90% of their same day, they're urgent on the same day. And you'll note that from October, we launched the online consultation programme for routine appointments as well. So you can see where it's going in terms of practices managing their own demand differently on the day. That is counter to what we want to achieve in terms of neighbourhood health and continuity of care. So we also need to think about how we support those with ongoing health needs in different locations. And that's why working with the Community Trust will be so important in terms of how we move that forward.
Thank you. Thank you, Chair.
My question is on the general practice access part. Is that okay? How does the 52%, so this is on the point 6, James, how does the 52% compare to perhaps a national average or even comparing to cities? I appreciate you might not have the information.
Nationally, it's circa 46-48% mark. It does differ in different geographies because of age profile and demography, but that is a high figure for Hampshire and the Isle of Wight. We're circa 48% elsewhere, so that's quite a high figure. which may reflect the nature of the presenting demand, but also the communities in which people live and the demography as well. And as Leslie said, the fact there's more routes for same-day demand to be managed may also create an additional bit of context there as well.
Thank you. I know some of these GPs. I noticed Round Health Centre is 18% up on appointments year on year, and it's one of the highest growth rates on the table. Do you know what's driving this, and is capacity keeping pace?
I can give you a bit more detail at another time in terms of the profile of the demand. I think they're one of the practices that have really taken on board online consultations. So I think a lot of practices have naturally seen an increase in how online consultations for routine needs are met. There's also been additional resource into Rowner in terms of GPs and practice staff. So again, that provides the flexibility to see more in that area. So the usual reasons I would suggest, but happy to look to see if there's any other profile changes of that practice. And obviously, should make the point, all practices work as part of a local transformation programme. So we've been working with all of our practices around capacity and access improvement. So there will be some commissioned actions that drive that as well.
Maybe my follow-up question is answered by that then, because the other one is Willow Group is up quite a lot after a bit of a dip, and I know there's been a merger there, so maybe that's just the numbers coming through.
Yeah, business circumstances will drive it. All of these practices have action plans. All of these practices have agreed areas of focus in terms of access improvement. The other point I made before is that just because practices are seeing more, that doesn't mean the patient satisfaction is higher. It does differ, so we need to look at different reasons in terms of determining performance.
I mean, the stunning increase was Craneswater group practice. Is there any particular reasons for that can be shared?
I think similar to the answer just given. There will be some staffing profile changes in those practices as well. We note there's always been a concern in Portsmouth that we don't have enough GPs compared to national. I think we have seen some improvements across the patch in terms of recruitment. Changes to the GP contract means that the primary care network monies can now be used to appoint additional GPs as well. So additional levers around appointing to new posts will be helpful.
Well, I think we should certainly thank you and the GPs that have GP practices that have really made some quite considerable changes, and hope that can continue. I think when I have a surgery and there are people coming in to talk about all sorts of things, people are still telling me stories of waiting for days and complete lack of communication and those sort of problems. How can we publish? I mean, I've been reading these figures quite consistently over the years, and I sometimes even whip them out and say, well, actually, this has improved this much, but a lot of people don't believe figures anyway. How can we improve the communications around this sort of thing in a sensitive way?
So I think we often are asked to update on access and access improvement. There's also something around managing expectation as well. So when patients do wait for, say, 28 days, that's often part of a treatment plan agreed with the practice, or it's very much in line with their healthcare needs. I would hope with the changes to online consultations and more urgent cases being seen on the day, we can give patients assurance that they will be assessed appropriately, they will be triaged, and if that need determines, they will be seen on the day or the next day. So I think we need to recognise that beyond access, there's good reasons why people can't be seen, but that doesn't mean their needs aren't being met in an appropriate way. So I think it's a mix of where there have been improvements, but also reminding patients around what they can expect from a practice and how they're supported in different ways. The big thing we pushed across the ICB started in Portsmouth, and that was it takes a team. So we're encouraging everyone to remember that primary care isn't just a GP. If you're not seen by a GP, you might be seen by a pharmacist or a nurse or a social prescriber. And that's been really helpful, I think, in extending access, but also managing expectation as well. But there's still a long way to go.
Thank you very much. Thank you. I think we need somehow to start to be able to publicise some of these figures to dispel the kind of ongoing rolling complaints that I hear at my surgery, and I'm sure other councillors do too. Do you? Susie?
I was just going to say on that on that note, Judith, I think for a lot of people it's not that they're not seeing a GP, it's that they still don't quite understand the complex landscape. And so you ring your GP, like if you've got a problem with something, and you're kind of the culture of it in the past was always you rang the GP. If you're then signposted to someone else, for most people it's fine, but I don't think people always still know where to go. And I know there's a lot of communications around, you know, the what are they called now? The old walk-in centres, what are they? Whatever they're called. Yes, the treatment centres versus the GP versus A&E. We put a lot of information out via schools around what to do when children are ill and everything. But it's a far more complex landscape than it has been for decades before that. So I think it's I don't think the comms will ever be kind of complete. But it's just about keep pushing and trying to, and then when people experience it, they will know what to do next. But I think it's a good point to raise. But sometimes people don't quite know where to go.
Good point. I think that's very important. Have you got any figures yet about how elderly people are getting on with online communication, particularly elderly, but also there are a few others in the population who are not au fait?
So the performance figures for online consultations doesn't break down by age group, but what I can say is all the practices in Portsmouth are compliant with the regulations. We track it. It's also tracked nationally now because the procurement of the systems to enable consultation also provide the opportunity for NHS England to monitor and access the system centrally and look at how appointment range is picked up. We do audit, and we still have some concerns around those that don't access smartphones or technology are digitally excluded. You can still be seen by a GP on the day if you can't book an appointment through the route. So we're not precluding people from doing that. But the message is always, if we can manage more people appropriately via an online channel, we can support more complex people on the day in the surgery with GP-led treatment as well. So it's achieving that balance to ensure we've got enough capacity to deal with the complex and the urgent. So we don't have to report it by age breakdown, but I can see if I can get any anecdotal evidence in terms of impact and improvement, if that's helpful.
Thank you. I certainly think this is something we need to go on monitoring. I have some concerns about the impossibility of people now who not only don't use computers or have smartphones, but would need a home visit because for some reason or other they are immobile or live in a hermit sort of way. How does that work?
So they can engage with their practices. They can make practices aware of particular needs. One would hope practices would be aware of individual circumstances. People can still ring surgeries as well. They can still ring surgeries and book an appointment. There's still a route for that. And that's a way of looking at broader needs when we assess patient satisfaction as well. So it's an enabler rather than an excluder, but the traditional routes still exist for patients who can't access new ways of appointments.
In the old days, we used to talk a lot about winter pressures. Have the winter pressures been exceptional? Are they beginning to come to an end, or is it sort of a year-round picture nowadays?
I'm sure Simon will talk about winter pressures from a hospital perspective earlier, but if you look at across Hampshire and the Isle of Wight, 5 of the last 6 months, we've seen over 1 million appointments. October was the biggest, 1.4 million. I think if you add up every month divided by 12, we have a 1 million appointment rolling average now across general practice. That doesn't necessarily mean that will have a significant impact on the front door of the hospital, but it does reflect the fact that the whole system's busy and the whole system's doing what they can to manage that demand.
Thank you very much. Now, moving on to the next part of the report, which is the Oak Park Diagnostic Service. Was there anything else you wanted to say about that that you didn't say in answering earlier question?
So, Chair, there would be a lot more I'd like to say, but unfortunately, because we're in a formal process at the moment, I'm really limited what else I can add to what I've said previously at the moment.
So just in relation, I was trying to put my hand up for the previous one. I just wanted to comment that our active wellbeing strategy, the social prescribers are working very well with our Get Up and Go and active team, and that's been very well received. And I think that has an impact on the number of people asking for appointments. So I think that it works very well. So anyway, but what I wanted to ask was about the Oak Park is that the GPs. What communication have you had with GPs in the area about the change to the services? Because when I inquired, they said they hadn't heard anything and were still thinking that the services have been withdrawn. So what communication plan have you got? Thank you.
So when we were able to share appropriate information, we did. Practices were made aware of alternatives. They were also made aware of the reasons by which they couldn't access services currently. Clearly, it's important also that we remind practices that how they can manage patients in general practice. A number of them have extended services, so we may have needed to commission that in a slightly bigger way than we have done previously. Some of it's about re-establishing pathways and giving them advice on where patients need to go. As James said, the hospital have been really helpful in terms of some of those core diagnostic services. So our communication has been more about what's the issue of the moment and what the alternatives are. As James said, we can't get dragged into why they're not providing services and what that means for the future. There were two other points in the report I just wanted to touch on when I can, Chair, but I think you had a question for me first.
First.
Thank you. I was going to say the report was read, but I think it's really important just to recognise that there was a fire at the beginning of February in University Hospital Southampton, and 500 patients were evacuated within 40 minutes from the wards. Within the next couple of days, over 200 patients were evacuated from the hospital. A significant number of them went to the QA, and a significant number was supported by Hampshire and Isle of Wight Healthcare Trust and other organisations. And I wanted to formally recognise that. As the Integrated Care Board, we were the Category 1 responder responsible for coordinating the systems level response. But partners really stepped forward, including the voluntary sector organisations, to support those patients in Southampton. And that support is still continuing now, so it's well over a month later, making sure that there's additional operations available to patients that might have been disadvantaged because their appointments were cancelled, have been re-provided, some by QA, other organisations. I just wanted to recognise that. Also, the ambulance service had a phenomenal response. There was a 30-hour ambulance divert, so a significant number of ambulances that would have gone to Southampton Hospital and over those 30 hours went to Portsmouth Hospital instead, and to Hampshire hospitals. And I just wanted to recognise the ambulance service and all partners, fire and rescue as well, that have been involved in that significant response.
Thank you, Chair. I was just going to ask more about the Southampton Hospital in respect of, do we have a timeline in respect of it being repaired? And ongoing, that's quite a lot of impact on the surrounding hospitals. Are they able to take that strain? Have they got that flex? Because obviously we come every year and we hear that there's a massive demand on hospitals, etc. But you've obviously absorbed these patients. Have any of them gone into virtual wards? Have we looked at a different way of looking after these patients in this time of stress? And hopefully there'll be some positive learning to come as well. Thank you.
Thank you. And also to recognise the councils as well. So Portsmouth Council, Social Care have also been doing a lot to support patients at home. So additional capacity has been brought online. Colleagues from Hampshire and Isle of Wight Healthcare Trust have also increased the number of virtual wards and people being supported at home. So a significant amount of additional resource has been found within the system to make sure that we really provide some of the capacity. At the moment, there's about 140 beds in total out of action in Southampton Hospital, and that's not likely to change for a significant number of months. That's the latest reports we've got. So system partners are learning how we will manage and support our patients with that deficit of bedded capacity we had previously. I'm sure colleagues are going to say more in their reports as well.
Somehow we've managed to leap to the things that are on the paper under agenda item 5. Can I just return to question about the Oak Park Diagnostic Service. Is the Oak Park Diagnostic Service, are diagnostic services based in local communities, the shape of things in the future, or are they things left over from a different past?
Thank you. It's a really important question. So we see neighbourhoods and local services really as the future of how we deliver health services that are tailored to local communities. Where it makes sense for services to be centralised in highly specialist areas, of course that's where it will be for the public purse and for public access and to access specialists. But where neighbourhoods are the right place for services to be delivered close to where people live, that's absolutely the direction of travel. So that's national policy, but also we've got a really strong process in working out what neighbourhoods will look like with council colleagues as well. So we're working with social care colleagues and local authority colleagues on the future of what neighbourhoods will be. So very much closer to home where it's practical and reasonable to do so.
Thank you. Anybody else? Any comments on that? Yourself.
Thank you. Do you want to? Thank you. Thank you. So I think there's a number of Pride in Place programmes across our areas, and I've certainly noticed in the stats that there seems to be more demand in those areas for health. I was wondering if there is any systematic NHS engagement with Pride in Place programmes across Portsmouth, or whether this is just happening ad hoc.
Yeah, there is. So we have a designated lead for that in the ICB. There's been a lot of interest recently in primary care, so conversation with them around pharmacy and pharmacy access. And we've spoken about that. And I think there's opportunities also to involve Pride in Place in terms of neighbourhood health and how that changes service profile and how people access. So yes, aware, yes, engaging. But again, there's probably more we can do in the future with service changes as well.
Thank you.
For the public listening, we've got 2 Pride in Place initiatives in Portsmouth with budgets. Are there any others in? You've got?
We've got 2. We've got Lee Park and Weacock Farm, which is Cowplain.
Sorry, I've got Rowner in Gosport.
They're all the same places that we all worked on with SRB and Children's Fund, aren't they? Which is means there should be some experience to draw on. Thank you.
Sorry, because it's hot off the press, but it came up last time in terms of Uni City practice in Portsmouth. Previously, they had a more challenging CQC assessment. They've now improved to good, so there's been a considerable improvement on where I reflected a few meetings ago. And broadly across the Portsmouth practices that have gone through CQC, majority have either maintained a good or improved to good. We've got 1 or 2 we need to work with, but again, quality in some of our practices is going in the right direction.
Thank you. There was a statistic about them, wasn't there, in the list here? Oh well. Thank you. We'll move on to agenda item 5, Hampshire Isle of Wight healthcare update. Wendy Rees.
Thank you so much. So hopefully the update is helpful. There's just a couple of points I'd like to just bring out of helpful. I think obviously the increase in the home-based rehab was a big scheme that, thank you for your support in November. We've mobilised that now. We have moved the resources from 20 beds at Summerley into the home-based team that's already established called the Community Response Service, which is a joint service with Portsmouth City Council. So we have increased our spaces for people in that service, obviously reduced the beds at Summerley to enable us to do that. It's a new change, so we mobilised at the end of January, so we're sort of in the first sort of few weeks. We're working really closely with Simon Barson at QA to make sure we are still meeting the demand. We appreciate there's still a lot of work to do around our ability to get people home from QA in a timely way, but we have seen an improving picture, not a worsening picture, which is great, but we do still know we've got a bit of work to do. Obviously, we did it at a time when there was a bit of a seasonal increase in demand. Not always a good time to do anything in the NHS, but why not do it then? It did mean that we did have additional capacity over the winter period for people to be supported at home, which was obviously better for them, less contact with germs. So that was really positive, but you know, we are still working on it. We presented the work to, because we've reduced beds over at Petersfield as well. We presented the work to the HASC last week. James Roach was with me. We've agreed to give us sort of an evaluation or a bit of information in 6 months' time, give us time to have a look at the trend data, give us time to look at the improvement, if that's okay, and we're happy to share that with you. We are obviously monitoring it daily, and we are also got a bit of oversight from NHS England on our sort of discharge through the Discharge Action Group. So we're closely monitored, and Simon will agree on that. So we are working on it, but I think it'll be helpful to give us sort of a bit of a view in 6 months. At the moment, we've sort of redeployed staff, which is really great. We're sort of training people up. We've got some adverts out because we've obviously moved some money, so we've got some more posts, which is great. We've reviewed the job description as well, so we sort of modernised that and making sure that we're delivering what people need. And that's really attractive to people as well, to work in that sector. We've got some careers for young people, placements. People just started with us, youngsters at 18 that have started in that team as well. So it's a really exciting start for building that workforce. And then obviously over winter's still apparent till after Easter. And then obviously in the sort of spring months, we're able to sort of revisit the model and make sure that we are delivering exactly what we should be for people. But so far, it's looking positive.
When you say looking positive, are you measuring outcomes for people?
Yeah, so at the moment, I mean, it is a bit number crunching at the moment. So one of the things that we wanted to make sure we didn't do was lose activity. So we wanted to make sure that we hadn't reduced the number of people coming out of QA with this change. We obviously are looking at an increase in the future, but over the winter months, we wanted to maintain our activity across what is the bed base and the home base. So we're trying to flip it the other way. So we were originally doing more bed-based transfers, less home base, and we're flipping it to more home base and less bed base, but we wanted to make sure we didn't lose activity. So we've got similar amounts of activity, but a shift to the home base. And obviously, as we build up the workforce, what we want to do is have an increase in the total capacity. So we've maintained our activity, and there is a slight decrease in weights for home-based rehab. So around the winter months, and Simon might correct me if I'm wrong, people sadly are waiting around 9 days to get home from QA for a sort of a home-based pathway. And it has reduced sort of in December. We were seeing it at about 8 days. So not where we want to be, but it's going in the right direction. So it is early days, but obviously that's what we want to monitor, the timeliness of people getting home, but also the ability to keep people home and not be bouncing back into hospital. With the home-based rehab service, we do need to recognise that it doesn't just do discharges. The service is there to stop people going back in as well. So it's really important that patients might have a bit of rehab from Queen Alexandra, might go home, have a period of time when they're okay. They might then wobble again, and this team can go back in and then build them up again without there needing to be a trip back up to QA. So that's what we're working through, and obviously we're trying to evaluate the entire experience for the person at the moment as we're building that service up.
I just wanted to say, I mean, those are all activity measures. Are you measuring whether people are living longer and in better health as a result of getting this input?
I mean, we measure that as partners anyway. We've been measuring a lot, obviously, with the winter months around how many people we keep at home well for longer. So obviously we measure that for our sort of hospital at home on all our pathways. It's really important. So we've got some really good indicators over this winter, particularly, that we did keep more people at home well. And I think as part of the winter evaluation, we'll be able to report that. But I think these measures are really tricky to do in isolation, because often patients that use these types of pathways have used lots of other parts of pathways too. So we try and look at it as a whole, but that there is a recognition that actually we did reduce the numbers of people that were admitted this year for sort of urgent care than we had previous years. I hope I'm right with that information, guys, but that's my understanding. And obviously, as we look at the winter metrics, we can make sure we accurately reflect that.
The other point I think is in the report, and Wendy might come on to, is how we deal with some of the complex needs differently. So palliative care is referred to. Some of this is about supporting more people at home in the last days of life. We've invested more in the hospice sector to enable them to do that. So Rowan's Hospice had an additional, I think, 1.2 million investment last year. We want to continue that in future years. So we've got to make sure there are approaches to discharge a whole pathway in all organisation. And often some of the more challenging delays are for a smaller group of people with more complex needs. So that's why we're trying to make sure we invest in the right parts of the pathway to enable that. The challenge, as always, will be getting the sufficient scale to have a demonstrable impact on the number of delays at hospital. So we are looking at it in different ways. But just to make that point, it's not just people with general needs, it's people with really complex needs and need a particular outcome. And that needs commissioning as well.
Thank you. Will, Susie, you wanted to go ahead?
I actually wanted to speak to two things on here, so I can either do them both at once or I can and do one. So what I think I'm picking up on a point that Leslie kind of alluded to, which is the learning from the fire and linked in with this, because we're always told that people are best off not in hospital where that can be possibly achieved. Obviously, a fire necessitates really, really quick and swift and urgent change, and I'm sure at great cost, because there'll be contingency for things like that. And I know I'm always conscious when you come up with ideas about how things could be different, that there is a real system of finance around this. So I suppose my question is, has there been immediate reflection and learning on the speed at which people got out into the community? And in an ideal world, would those people have been not in hospital in the first place? Which I guess these two pieces of work coming together. Now, there may well be some people who are in the community as a result of the fire who still ideally would be better off in hospital. But is there an opportunity out of a really awful circumstance to actually change some of the practice to accelerate one of the streams of work that we're doing anyway, is my question.
A really good question, and absolutely, yes. I mean, I think the fire, it did demonstrate to us our ability to very quickly respond to what is a capacity requirement above what we would normally provide. But it did come at a cost. And it also came at a cost of not doing other things. So and maybe because we were in winter, we were already sort of front loading our urgent capacity anyway, at the detriment of other things. So we were sort of almost primed. But it did mean in the weeks of responding to the fire, we did very little else, which will have an impact on planned care. So for people, say for example, in community nursing that were waiting for a vitamin K or B12 injection, they may have waited 2 more weeks. So there is an impact there. But in the Southampton Southwest area, where obviously the main impact was, there is accelerated learning and consideration of what could look different. They've got Lymington Hospital, which is obviously a very active site and already provides some medical ward, and so it is looking at what that offer could look like. And in this area particularly, we've got the great services we have in St Mary's and what is the Amarie unit, which is a jointly provided unit with Portsmouth, we've actually gone, actually, we actually know we can do more now, because we've learned actually that the patients that we did support, and Simon, obviously, Barson team looked after very sick patients that needed hospital care, but the patients we brought out a bit earlier, we went, actually, we did do okay. So it's absolutely really important. I mean, in addition to, obviously, the investment we've had for hospice care, we had £1 million last financial year for hospital at home, so our virtual wards have increased as well, which enabled us in this instance, because we just scaled that up, to have that capacity ready and running. So that capacity is still being used now. So we're still using the additional capacity that we had put online for the fire, because actually the patients were appropriate. So yeah, lots to learn from that. Thank you.
Yeah, it was the end of life stuff. I just have, I suppose, a bit of feedback, but also a question about that is, having been somebody, which I'm sure a lot of people in this room might be in the same case, where you've been through this experience of going up to QA and spending a fortune on the private car park every day whilst a family member is not likely to come out. It's a really I think there are potential for improvement, and I haven't actually, I'll be honest, I haven't read the link on this, but I will go and read it because it's something that I feel really passionate about. And I suppose my feedback would be is having more clarity around this and the communication you get from the hospital to the family around the options that there are. And I know it's really difficult for people in healthcare to give definitive answers, but actually, on a personal level, I think I would have preferred some more honest conversations around prognosis and also opportunities for going home if necessary. So I suppose my main thing is I'm really interested in this, and I think it's a really positive move. But actually, palliative care has a different ethos to other healthcare. It feels like that anyway as a family member. And I think the link between the hospital and potentially going home for end of life, I think there needs to be some more joined up thinking.
No, thank you. And having been a community nurse, I think, for the majority of people, we are able to keep people at home safe and comfortable at the end of their life. The problem is that people have different symptoms that require different responses, and and things that are quite upsetting and distressing for families. Often things like breathlessness and that type of thing, that families will often sort of encourage a pop up to QA or a hospital because they're so worried about it, and you can understand that. I think what this changes, which is really great, is that there is an end of life link now in the emergency department. That's able to, so if somebody does come up, and sometimes people do need emergency care, that they're able to have the emergency care, but then there's a swift return, because I think that's the key, is people get stuck, don't they? So I think that's what this change is really good for. But Simon.
Yeah, I'd agree with that, Wendy. And I think if I ask my emergency physician consultants what is the best pathway that's been put in place in the last 12 months, they would say it's the alert pathway. Because they're the ones that are initially seeing the patient arrive, who they know is end of life, who they know, to be honest, their value add as a clinician is going to be nothing. Having to be able to pick up the phone or having somebody in the department who can literally, to some degree, scoop that patient up, get them safely home, to have death with dignity has been really key. So I think out of all the initiatives we've put forward as a system, it is the one that I know my front door team will rave on about forever, because they find it difficult. You're admitting a patient who you know full well needs nothing other than a respectful death. This has really given them access to a different option for that patient cohort, which is really positive.
Thank you, Susie. Under the additional resource given to the Rowans, have they been able to open some of the beds that they closed, 2-3 years ago, as a result? Because they were operating under capacity because of lack of finance fairly recently.
Yeah, I can check the number, but the aim was to build on existing capacity to meet need. But also, I think traditionally hospices have relied a great deal on trust funds and charitable income. Some of this was about redressing the balance between commissioned NHS income and charitable income. They would have used that both to enhance their internal capacity, but also, as this example demonstrates, work very differently with partners. as well.
Yes, I think extraordinarily the hospice sector was the sector of what people think of as the NHS, which wasn't funded by the NHS. I think this is a tremendous move to see it as part of the NHS system, and therefore a little bit more amenable in some areas. I think the Rowan's has done a great job, but that's good. Mark.
Yeah, I don't know if you covered this and I just missed it, but when will the Southampton Hospital be sort of working back to full capacity? Does that, and are there plans in the system to be able to cope with it if it's going on longer?
So it's going to be months rather than weeks, looking like potentially 6 months. There's still work happening to look at the damage that might have been caused and what beds can be brought back online. So at the moment, they're still about 140 beds short of where they started, and that's where partners like Wendy and others have re-provided different types of care. So at the moment, we've got over 200 additional places of care out of the hospital setting to mitigate for that 140. So there's more care available as in places than we had previously. So we think it will be at least 6 months till they're back to full establishment of beds.
And I guess my follow-up to that is, has a similar sort of thing happened west of Southampton? So has all the additional sort of capacity needed to be taken from our area, or has it been sort of spread around?
So I'll ask Wendy and Simon to comment on that further, because we've all been part of developing what we've called the out-of-hospital capacity cell. So all partners have come from all organisations together to think about how can we re-provide additional capacity. So much like trying to support QA to take additional patients from Southampton, it was how could we then create additional capacity outside of the hospital that QA patients could go into. So it wasn't just centred around Southampton, it was more Hampshire and Isle of Wight wide, the majority of which around Southampton space, but also how do we support the other hospitals and localities.
Yes, I think as part of that total response, it was a total system response. So acknowledging that, so from a QA perspective, we took 80 patients from Southampton into our bed base who were predominantly all not at the end of their pathway, so they were still unwell, required treatment, or they came via ambulances. Amongst that, we also took a large volume of cardiac patients needing cath lab work. So again, it was a response to the immediate position. We're now in a bit more of a recovery phase as an organisation, so we're supporting them with key elements of work. So, for example, through the fire, they lost their endoscopy unit in totality. So we still are continuing to support the Isle of Wight Trust with out-of-hours bleeds that would normally have gone to Southampton, are still coming to us at the moment. And we're also supporting with some complex respiratory work, where again was a diagnostic piece of work that was run out of their endoscopy unit, which burnt down. So again, we are still supporting elements of that. But I think for us, the core elements we responded to within the first 2 weeks, we've now kind of rebalanced out. I think the challenge is, as James described, how do you keep all those efficiencies and progress around out-of-hospital work going when the rest of the world is flexing back to a normal state other than the UHS position. So it is a ongoing piece of work, and there are a number of work cells going on around how do you keep going with the positivity we've seen. I think from a hospital perspective, we dealt with the initial acute response to the fact they had insufficient capacity to manage their acute, and their ED was shut, which on a Sunday, when you get the phone call at home, was quite an interesting conversation to be having. I know James was on call as well at that time. So we had to really flex internally and respond to that while making sure that the total population was safe. Because the worry is you move the problem to Winchester or ourselves, if those two hospitals then equally begin to collapse, you've now got one hospital that has no capacity to take, and two of us that are now overwhelmed with the capacity. So it was I think, a unique experience is how I would describe those first 2 weeks, particularly at QA, but also from a Southampton colleagues' perspective. And I think it was that response to colleagues, I think, key. The teams at QA, the teams at UHS, they all have WhatsApp groups, they could all understand the challenge, and I think that response was very rapid in terms of giving that additional capacity as required to the incident as it was progressing.
I guess my follow-up is, because of the geography, obviously, it puts particularly more strain on the hospitals, obviously, to the north of Southampton and west and east. So do you get any extra funding at all from government to offset any of the additional work that you'll be doing?
So the additional work we're doing currently is under a tariff. So if we see the patient, we treat the patient, we get the money for the patients. I think there's an element that probably James may be better placed on. There was obviously a bill cost. When you take on the extra work, it's not extra to the tariff, but things we did at short notice in terms of, so within 12 hours, we had additional ED consultants on shift. We had additional geriatricians coming in because we opened up a unit within the hospital that was basically the UHS receiving unit. And these patients were coming across, given the challenge, we're coming across with potentially their notes, potentially not their notes, potentially not their meds. Some of their phones had been lost, etc. So we had to put a full clinical team into that unit to treat them as if they literally come through ED. And nobody knew anything about them kind of scenario. So that all came at a cost that we continued for at least 2 weeks. We opened additional beds. Again, you need the additional nurses. So some elements were immediate costs that you just had to do. There was no way around that. The ongoing bits is more probably some of the elective work that we're still picking up that obviously we'll get the funding for, but having that initial bill, again, alongside I imagine a significant insurance bill at Southampton, is probably still being worked through from a finance perspective.
I don't know if there, I think, Wendy, you probably did touch on this, but actually, do we know how much this is going to impact on things that would be happening if this incident hadn't happened to people in the QA area? So I'm guessing, but I might be completely wrong, that this might impact on people's health in the Portsmouth area because they're not able to have procedures so quickly compared to if this incident hadn't happened. And I totally understand why the support and care should be given. I'm not arguing against that at all. But actually, is there any concern over health outcomes for people in the Portsmouth area because of this?
No, so our response really was to increase our ability to support people in the Portsmouth area, to enable Simon Barson's team to support people from the Southampton area. So we actually didn't support anybody from Southampton. We only supported our local population, but we did it in a slightly different way so that it released capacity in the acute trust. So so I think patients did benefit probably and hopefully some positively by the additional capacity. In terms of having to step down some of our other care, we did it in a way so it was a sort of a very intense 2-week period. We obviously clinically triage all of our demand every day, and so we did obviously, some people had to wait a couple of weeks for some things that they could wait for. The capacity we increased with people like me working clinically and not doing my operational stuff like my finance and stuff, which I didn't mind at all, and not writing any reports and going to meetings. So actually, it was us increasing the capacity, which was really nice. So. Not that we want it to happen again, but it is quite nice. But to be honest, in winter, we do quite a lot of that anyway. We release capacity from an operational team. And luckily for me, I've got an operational team that's all clinical, so it's quite easy to mobilise that. But yeah, we haven't seen an impact, a detrimental impact for people in the area, or hopefully, not that I've seen. Thank you.
Brilliant, lot of questions.
Just quickly from a hospital side as well. So from our own patient cohorts, we didn't delay or cancel any of their treatments. So this was genuinely above and beyond. So we put on additional capacity where required. We had teams that would, if an endoscopy list was going to finish at 4, they'd run on till 8. So they'd fill the list with those patients that came across from Southampton instead of cancelling hours to mitigate that. And I think it's probably worth noting, I know James had put it in the response, but from our perspective, the best thing we saw as part of that was probably Hampshire County Council as well. So we took a cohort of patients that were genuine Southampton patients. So some lived in Lymington. Once they came to us, we could treat them clinically, but then knowing what service to access potentially get them home to our clinicians, sometimes it can be challenging enough within the Portsmouth population to do that. When you're looking at something that is miles away, it was really tricky. But I think the wraparound response, particularly from Hampshire County Council and Wendy's colleagues on the other side of the patch, meant that those patients were appropriately taken out of the hospital at pace back to their local communities as quickly as possible, which I think was really key, because our anxiety was, as soon as they become fit, if we can't get them out, they're going to be stuck in a hospital that is quite far away, and we weren't clearly in a place where we could phone Southampton and say, do you mind taking the patient back? Now they're fit, because they were in no state to do so, but I think the responsiveness from community outside of the Portsmouth system to get this patient back was really impressive to see, and it was a very rapid, they are now fit, they were scooped up, and some were obviously discharged on their own steam, but those that couldn't be, there was a real fast response from system partners.
So from that piece about Southampton General Hospital, I'd like us to specifically minute what you said, James, elsewhere in the agenda was a huge vote of thanks to the staff and colleagues across the system for their dedication and adaptability during a challenging period of disruption. That you really, it seems to me that the NHS as a system of partnerships really rose to the challenge, and I have not heard anything else, and it is the sort of thing that we do tend to hear about in this day of media looking for issues, and so thank you very, very much indeed. And we need to record our, you know, it is a very unusual circumstance, thank goodness, and it does seem to me that you've all joined together to do some great work in the interest of patients. Have we talked about helping people avoid hospital at the end of life? I think we've had questions of that. Do we want to talk at all? Anybody want to answer questions about the Solent Mind peer support change? Go ahead.
Thank you. I really like the sound of the Solent Mind work, but is there any evidence the new referral pathway is reaching the same people as the old walk-in model, and what is the risk of low help seekers falling through the gaps?
So in terms of the Solent Mind contract, so we're on that piece, aren't we? Just to clarify, so we have reviewed the contract. It was due for review, and we've reviewed the contract. So we have made some change to the contract, but I just want to reassure you that the provision in terms of the sort of funding available is the same. We've just altered how we provide that. What we found with the peer contract in the city was that we had some in-house employed peers and some Solent Mind employed peers almost delivering in the same place, and there was confusion and sort of supervision and sort of workforce issues associated with that. So the decision was that we would bring some of those peers back into in-house. So we now run what is the secondary or the sort of community mental health team and inpatient element of the peer service. We run that ourselves, which means the peers are part of our teams, which is great. In terms of the sort of primary care or the sort of positive minds or the sort of the more sort of preventative group work, that contract is with Solent Mind. So the contract's only just switched over. So at the moment, I think there's been a little bit of a gap in terms of the switch over the contract and what the delivery might look like. It might look exactly the same, but I think what's happened is there's been a slight pause in terms of what the switch might look like. So apologies for that. So I think what I propose, if it's helpful, is that because it's only just changed, would it be helpful at the next HOSP to bring our Solent Mind colleagues and our lived experience leads from our trust to the meeting to talk through what this may look like for people, and we could do a piece on that rather than it, because it's just swapping over. I probably don't have the detail to hand, and also for Solent Mind, it is their provision, not mine. Is that okay?
Thank you.
Would we do that in 8 weeks? What would be a good time scale for that? And I'll make sure I invite them.
Lisa.
Yeah, just looking. The next meeting is the 11th of June.
Is that okay?
Is it possible? I've noted that there's a new contract for the new autism and ADHD support for Solent Mind from April as well. So is it possible to get a sort of briefing about that, how it dovetails into it, if that's okay with you, Chair?
Yes, we'll run through. Okay, so the next briefing paper, Agenda 6, is the Portsmouth Hospitals University Trust update. Simon has already helpfully joined in. This just tells me that I think we should be doing scrutiny looking at a care group across the system rather than by organisation, because it's quite difficult when you're all wanting to chip into all the papers, quite rightly, because you're all working so well together. I wonder if we might talk to Leonie and have a little talk about that. I know that some of the problems that occur for patients is a transition between one organisation and another. And chairing this sort of meeting quite a long time ago now, I don't recall so much chipping in going on in the discussion, which is a really good sign. And Susie, what I'm saying is that we've got these papers on organisations rather than on...
Yeah, we can
care
discuss
groups.
it outside, but I think there's a place for both,
Yes,
actually,
yeah,
because
probably
I really like the idea that I really like it when something comes up and that they all chip in,
Yes.
because for the very reason that you're saying. But I do think maybe an idea about cutting it the other way as well, looking at service user, is a really good idea, but I think we can do both.
Yes, well, probably it'll be up to the chair of the chair after the elections to talk about anyway. But it just made me feel, especially so much chipping in. Simon, your chance to talk to agenda item 6, and of course everybody else can join in if they want.
I'm sure they will. Thank you, Chair. I'll take the document as read. I think some key things to pick out in terms of the emergency department waiting times. So we achieved 72.7% for January. That did improve in February to 73.01%. So despite the challenge at the beginning of the month with the Southampton fire, we managed to sustain and it marginally improved that 4-hour performance. And also worth noting that we have so far seen 10,000 more attendances through our ED alone than we would have expected to see at this time of year. The other thing probably to note, and I think we discussed this last time we came, was that we have now got our urgent primary and emergency care centre open. So that's a combination of our own emergency department EMPs, so emergency practitioners, with our alliance GPs running out of a single unit within the hospital. They are a closed unit to some degree, so they take directly from the emergency department, and that's it. They are now in a place where they are seeing on average 134 patients a day through that unit. It's open 8 till 10 every day. And that does account for 50% of all of our walk-in attendances through the adults to the ED. So again, it kind of describes what James is describing around the primary care demands, the increasing primary care appointments. The predominant cohort of our walk-in demand is that more urgent care level patients than emergency care level patients. So that facility is working really well and is supporting that ED to decompress through the day, and also offers return appointments for patients as well. If they aren't deemed necessary to be seen there and then, they can go away and come back the following day or have a phone call consultation as well. It is worth noting ambulance handovers was challenged in January. That relates to the first 2 weeks of January predominantly, where we saw significant increase in demands and pressures around the bed base. That has improved for February, and February's position from a South Central ambulance perspective was the average handover time at QA was 14 minutes 52 seconds, and the national standard is 15 minutes. And again, that was on top of the demands from the UHS fire, which started on the 1st of February. Our SDECs remain an area of focus for us. Through January, due to bed pressures and demand, we developed a mobile SDEC service. So that's our acute medics as part of a team. Instead of bringing the patients to them on the unit, they were going out to where the patients were in the emergency department and picking out patients they felt they could turn around at pace and discharge, which was positive and helped decompress the bed base. They were discharging around 15 patients a day through that process, which was helpful. Our NCTR position did see a drop as part of the response to the fire, so we did see that come down as all the trust saw as part of that immediate need to release the trust capacity, and got down to about 220. It has started to increase slightly through February, and we are monitoring that with our colleagues around areas of focus there. And internally, we are doing some work also around ensuring that we are maximising pathways for patients to get them out of the hospital at pace. And as it's noted in the paper, we did our first day case hip fracture procedure. So that's a patient that fell, broke their hip, and we got them in, hip replaced, and out again within the day. I have asked also the team to do that for all patients. I'm being assured that is not possible for all patients, but in that case particular, a real positive outcome. These patients can spend a long time in the hospital with rehabilitation, and also they have a higher risk of not going back to the place they came from when they get admitted. So a real positive there. And we also have managed to enable one of our robots within our theatres to work as an emergency robot with the surgical team, which again increases positivity in terms of reduced blood loss in procedures, but as well as part of that, reducing length of stay. And it is the first one in the UK to deliver that service, which again is a positive. In terms of areas, just to update norovirus, so for those that probably from the committee will know, we had challenges last year significant around norovirus, so we had a sustained period of norovirus at QA, which at times had 50 closed empty beds as part of that. Obviously with winter, you do see noro, no matter how good you are at managing it, it does enter the bed base. But we have seen a more positive impact this year in terms of where we've got it in pockets, we managed to contain the norovirus in the pockets and obviously then stop it spreading. And then releasing those beds quickly. I think it's been absolutely helped by point of care testing in the ED, which I think we described last time we came. So we have a machine in the ED now that can test norovirus on entry to the hospital and gets a turnaround time of about 90 minutes from swab taken to confirmation of norovirus or not. It doesn't clearly treat the norovirus, so you still have it, but you at least know the patient has got norovirus and you can contain them in a different way than we have done historically. So that was another real positive there. I think we have discussed the fire at UHS and obviously the e-alert team as well. And obviously we've got some work in there around advancements in our technology around diabetes endocrinology, which Professor Carr is leading on for the hospital. We are quite fortunate to have Professor Carr. He's a national lead on endocrinology and diabetes, so it does give you the advantageousness of being a front runner in a lot of the new programs, which this is one of, and real positive for patients to be able to manage their diabetes more effectively and having automatic treatments given to them in a loop system as described in the paper. But I will pause there, Chair, but happy to take any questions on any areas.
Mine's hopefully just a straightforward question. So on the non-criteria to reside, the 256 beds per day, how does that compare to the overall number of beds, if that's possible to give that figure?
Yeah, so we have about 1,033 general adult beds at the QA. So it's about 25% of the beds, which is high within Hampshire and Isle of Wight and is high within a national position. So as an ICB, we are an outlier nationally in terms of that NCTR position, not just here, but across all the acutes. So yes, it does take up a large amount of beds, and I think as we described before, it's also where those beds are situated, because predominantly the NCTR patients are elderly in nature, which usually means they're down a medical pathway, which means they're in the medical bed base or the geriatric bed base. And of course, the biggest take all hospitals manage is that general medical take, which these patients come through. So it does cause pressures there that then can sleep out into the surgical world when you start outlying patients from the medical bed base to the surgical bed base to take up the take.
Thank you, Chair. I'd just like to shout out if your Facebook page, Portsmouth Hospitals NHS Trust, is fantastic, giving up-to-date information, and certainly for the norovirus about the wearing of masks in the hospital. And that, I think that really, those messages are really positive and the feedback is really exceptional. So if you don't follow it, I'd say follow it. I'm really interested in the amount of people who come to ED who, this is not judgment, who probably should have gone to their GP. Do we actually, because obviously your ED is for life-threatening illness and injury, and you've got people turning up who are not there for that. And it's great that you've dovetailed them off so it reduces those people going to the hospital and the wait time, etc., and the ambulances, and it all feeds in nicely. But are we asking those patients, in a respectful manner, why haven't you gone to your GP? Thank you, Chair.
Yeah, so we did, before we opened our UPEC service, we did a number of audits of the walk-in demand to the emergency department, and they were done by ourselves. They were also done by the ICB at the time, and ESIST, which is a national body. It is difficult to garner from patients the answer usually is, I couldn't get an appointment. But when you probe at that, it's not necessarily always clear that it was about the appointment. Some of it is around, well, I tried once, I couldn't get through, so I didn't try again, or I didn't wait for my call back, is another one. We also got quite a few through 111, so it's not necessarily a GP primary care. It can be 111, and we know 111 go off an algorithm, which is as appropriately so risk-averse algorithms, so they will convey more if they go through a 111 route than potentially if they've gone through a GP route. I think we always know it's an issue. We've known for a number of years, hence why we put UPEC in, that 40% of walk-ins are primary care in nature. And I think what is interesting when you look at the UPEC position, which we obviously monitor daily, the 134 patients they see, on average, 7% get admitted. So there is a cohort in there that do get admitted. They are usually fractures that are more complex than was first thought. So that unit doesn't just see illness, it sees fractures as well. But what we're saying is also, out of that, there's a large, well, the majority of the patients that go to that unit don't require onward treatment within the acute setting. It doesn't necessarily mean that we don't discharge them back to their GP for further follow-ups or to pharmacy, etc., because they have access to all the pathways, but very few of them get admitted. I think the percentage they get admitted for a medical reason is pretty much zero. It is those more fractures or dental pain, which is worse than first thought. Dental pain is the other one that we see a bit of as well in there.
Yeah, no, only just to add to that. So I think the primary care service in the hospital is a positive step, because at least you can educate people when they interface. We need to build on that to make sure that actually the guys can turn around on the day to an alternative. So it could be pharmacy first, it could be other things. The target change next year, which means practices need to see 90% of their urgent on the day, will have an impact, but it will shift the demand to another part of the system, so it will create an imbalance. The other point that Simon made around 111 is that we have started to put GPs in the clinical assessment service, which potentially provides the opportunity then for people to be redirected at source. One of the things we did in Southampton is we used our primary care network to do a walk-in Saturday and Sunday for people redirected from 111. So there are opportunities to address it as well. But people often present where they're comfortable presenting and they know they'll be seen. So we've got to change comms and be more challenging of our population in terms of the habits they have around attending as well.
I just wanted, it's okay, Chair, to put on record how amazing the ambulance waiting times have been reduced. Because I know certainly for a couple of years there was really serious concerns that ambulances were sat for 4+ hours at ED, not attending patients in the community. I just think you've done a phenomenal job where everyone's worked together, looked at how you can dovetail people off into different areas, and they've just done an amazing job, Chair. Thank you.
We'll certainly record that. I think there is in here quite a lot of good news that we've been very happy to share. Yourself?
On that, can you confirm that the discharge sprint model will carry on beyond 2025? It sounds like it's done a lot of good and yeah.
Did you want me to come in on that point?
Yes.
Sorry, yes. So the discharge sprint model is a sort of intensive period of time where we look at the initiatives that have been set up. If we take a step back, I think what you are seeing from us sitting here is we work on a daily basis together across all our different organisations, and especially in that discharge space. There's a local systems discharge improvement group that actually a lot of the people sitting on this table are members of, with other partners. And what we have is a development plan where we are looking at the improvements that need to be made. And a significant number of those are across organisations and the way they work. So it's not necessarily about capacity that's available, it's about how organisations are empowered to let their teams work better together and removing organisational blocks. And that's what we really start to concentrate on. So the 6-week sprint that we had with regards to discharge was just that. In fact, a lot of us were on the same call twice a day, trying to make sure we were empowering teams and moving some of those blocks out of the way. So that methodology will continue.
That's very good news, thank you.
Just to supplement that same question, I mean, 256 beds a day occupied by patients, bed blocking effectively, is still quite high. And is there anything that we as a local authority and other local authorities should be doing more of to make that happen?
So local authority are absolutely involved in the work that we're doing. So we're recognised nationally as an outlier with regards to the number of people that are waiting, that are deemed as no criteria to reside. So there's a significant amount of work that we're doing. We've actually got the national team from the Department of Health and Social Care working with us and our councils and the NHS to make those improvements. So there's work that all partners need to do. This isn't a one organisational issue. This is over a number of years. We've got systemic issues that we're all tackling together, but it's good that we've got the support from the national team that have recognised that we need the help in this space.
Councillor Horton. Susie.
It's only to, I'm just interested in the 10,000 more attendances planned. I'm wondering whether we know what that peak was. Is it linked? I mean, do you get data on why numbers are so high? Because I think it's really simple for us to sort of say, oh, it's because they can't get a GP appointment, but it's not that, is it? It's a cultural thing. Just picking up on what James was saying, because I was thinking that is like for some people, when you talk to them, they need to see a person. If someone had told me 10 years ago that I'd have a GP's appointment which was talking to a physio to describe and diagnose what was wrong with my knee, I probably would have thought you were bonkers. But actually, it was completely sufficient. But if I'm really honest, it was a bit weird that someone should diagnose a physical thing based on just a conversation. But do you know what? That was good enough. And it was good enough for everyone. It was good enough for the patient. It's good enough for the doctor's surgery, etc. So I'm thinking about the comms stuff is whether there could be something about, do you actually need to see a person or do you need to be heard? Which I think are two different things. And I was kind of linking it with that 10,000 extra people. That's a lot of extra people. And if they had an alternative, then it would probably be more efficient all round.
Yeah, and I said, I mean, 10,000 extra people in the hospital, there's tens of extra thousands of people still going into general practice as well. So I think it's a message more broadly in terms of making the right access choice wherever that point of access is in the system. So that's why we've pushed it takes a team, so people don't feel they need to go to a general practice. That's why we push virtual versus face-to-face. Through that, we educate our patients in terms of alternative points of access. It's very difficult to say to someone, you don't need to see someone or you don't need to be there. But we just use the opportunity to educate and appropriately challenge. But I think this is something we can do collectively with the local authority more in terms of there's limited resource, use it wisely, remember the alternatives, and think differently.
Yeah, I think I'd add to that. What we've tried really hard, and it's through learning from others as well, is that, for example, our triage process within our walk-in area is literally as you walk in the door. So there is a bit of crossing a threshold where you walk in and the nurse is there with the administrator who will assess you, and it is a very rapid triage assessment. So it's very much an eyes on, so they don't put anything on you, they don't do anything like that, and they'll assess you as you walk in and they'll go, no, you're not for us, you need to go around to UPEC. And it's how you start getting that in there. And then when they go to UPEC, they'll see a GP or one of the EMPs. And it's that continuing conversation with them around there were alternatives that you could have probably explored. I think the key here is that we haven't seen demonstrable increases in ambulance demand. So we aren't saying that the 10,000 is all about the ambulances. And in fact, our admission rates from our ED has dropped in the last year. So it would suggest that the numbers that we're seeing aren't converting to admissions. So it is a genuine walk-in pressure point.
Sorry, I just wanted to. I was quite interested in the patient experience in your chatterboxes with the Royal Navy, and because attention to patients' well-being and whilst they're in hospital. I mean, I presume you have library service as well, and books and reading. And I was just wondering how that is funded and whether that's how long is that a permanent service, or is it time limited through funding?
Yeah, so I think it's supported through a number of partnerships with the National Museum and obviously the Navy itself. So I think the funding, I've not heard that it's an issue moving forward. I think, like you said, it's been really helpful, and it's not just focused on, there's been a lot of work done in this around geriatrics, around bringing memories back to people. But as you can see, it is across the entire trust they do this, because, as much as, our elderly population will get the memory elation of this, the younger population also find it really fascinating and interesting. So it is an ongoing piece of work. There is no end point to that. But I think it has shown real benefits to patients from that experience. Yeah.
So the funding is the Royal Navy and the museum paying for it, or
yes, at the moment. Yeah.
Great, that's excellent.
No, that's really good. Mark.
Yeah, thank you. With the Pharmacy First sort of work that's been going on, is there any measure of knowing how successful that is? I've personally do use a pharmacy a lot for a lot of sort of initial conversations, as it were, and because I have to collect quite a lot of medication for me and other people, I'm quite often in a pharmacy, and I see other people doing it, which is great. But is there any sort of work done on that at all?
So we are very much focused on numbers of people who attend the service and across the pathways. We're also looking at how many referrals we get from 111 to see if we're truly avoiding an attendance at that part. Useful prompt, Mark, we just released a survey to the public around how they use Pharmacy First. Did they find it useful? Would they use it again? So happy to share that with officers here, to share with members as they approach elections, because I think it's a very simple 4-question survey accessible via a QR code. So it's a good way to promote Pharmacy First, but get insights as well around future plans.
I'm sure people will be willing to distribute those in whatever ways they can.
So
James.
thank you. It's just on the sort of communications engagement with local public, and I think it's a really important point we're looking at. I've been speaking to the Behavioural Science Unit at the Department of Health on this, because it's a national issue that everyone's trying to make sure that people access care as quickly as they can in the right setting. A lot of it is to do with lived experience, much to your point. If you've experienced something that's positive, you're more likely to do it again. So there is a bit about, as additional capacity is brought online, Pharmacy First is becoming more regular, people will start to use those opportunities more and more. But we do also have a communications channel. We've also got a Facebook page that we use for the Integrated Care Board across Hampshire and Isle of Wight. So the more we collectively do to message to the public different ways of accessing, and then that's reinforced with their lived experience, I think we've got a better chance of changing people's behaviours. But this really is a concerted effort that's going to take a number of years to really get people to access health in different ways. And I was struck with one of the reports James was showing me a few weeks ago. At points we had more primary care appointments than had been used in particular weeks. So that told me that there was capacity that wasn't being used by the public, yet people were accessing things like urgent treatment centres or going to ED. So it's about changing behaviour. And I think all organisations together are working really hard to try to get these messages out.
That's terrific. I think it's been really interesting. Are there any more questions on the papers? Are there any matters arising or any other business that you'd like to raise? And I'd like to end the meeting by, if that's okay with everybody, just pointing out the accreditation that PHU have got to gold level status as a National Joint Registry Quality Data Provider for 2025, highlighting the work of our orthopaedic teams. So pass on our congratulations on that. And I must say I've enjoyed the meeting and seeing the 4 of you working as one across the table here, and hope that everybody else has agrees how well our questions were asked. So thank you all for coming. And we said we'd have a brief discussion about agenda for next time. Well, I'm not the regular chair, so I suggest Lisa, I think you must have made a note of 3 things that were raised, and we'll leave that to Leanne to yourself.
So I just wanted to make one comment in the terms of the soul and mind, as whether it can cover Havant and Gosport as well as just Portsmouth, because it's very interesting. If we are going to look at that to be the wider, that would be great. Thank you.